Okay, because we do like to keep these right on time and be aware of everyone's commitments that they have throughout the day, I will go ahead and get us started. I want to thank everyone for joining us today. My name is Courtney McNulty. I'm the Content Solutions Manager at Unbound Medicine. Welcome to today's webinar. We have Dr. Paul Auwaerter, who will be discussing the latest updates regarding COVID-19, influenza, and RSV vaccines. So with that, please allow me to introduce our esteemed speaker. Dr. Auwaerter is a professor of medicine at the Johns Hopkins University School of Medicine, serving as the clinical director for the Division of Infectious Disease and the director of the Center for Environmental Infectious Diseases. He also currently serves as the executive director of the Johns Hopkins Pocket Center and is a key contributor of the Johns Hopkins Antibiotic Guide, which is published and distributed by Unbound Medicine. At the end of this presentation, we will have time for a live Q&A. If you'd like to ask a question, please feel free to do so in the chat or Q&A box at any time. And with that, Dr. Auwaerter, thank you for taking the time to share this presentation with us, and I will hand it over to you.
Okay, yeah, thank you so much, Courtney, and thank you so much for joining this afternoon. What I thought I would do is spend a few minutes just giving a little bit of a snapshot for each of these three important respiratory viral infections, and then a little bit about some of the immunization status and recommendations, which have certainly in some quarters here caused a fair amount of confusion, and which may not be entirely settled yet, I'll say as well. So future changes may be coming. So I'm going to go ahead and share my screen here. So I'm hoping to just give a little bit of information about, why is it important? These are important for our patients. Some of the vaccine recommendations as mentioned. I'll mention I have no direct disclosures relevant to any of these current vaccines. It's perhaps no surprise to anyone that one of the important sequelae, I think, of the pandemic has been the changing landscape of recommendations that were often very on short order and not always communicated effectively, or even later on, perhaps as balanced at times. That has caused a great deal of upset and distrust. And I just wanted to focus on some things which I'm sure all of you probably know, but just to highlight that some of the basis of this is that, especially for the COVID vaccines, the mRNA was a new technology that people were unfamiliar with. It was hurried through, thankfully, with, I think, spectacular results. But it was not a formally FDA-approved vaccine, and concerns have been raised about whether there's long-term safety given the novelty of the vaccine, and or just whether there were too many immunizations given, and there's a host of other ones more specific as well. And there are many barriers that I think have only been amplified more recently, both in social media, other people that will say they have expert advice and so on, that has sort of fostered, I think, an increase in vaccine hesitancy, a sense that there's danger in this, and perhaps also in terms of COVID, that it's no longer really that important. And so we'll just focus on some of these. I think will be helpful when you're perhaps asked questions or you're making a recommendation for our patients. So some preliminary data from the last year too from the Centers for Disease Control that were from this past summer still shows that there's a significant burden from SARS-CoV-2 here in terms of total infections, hospitalizations, as you can see, are substantial, and deaths, which certainly at least rival or at least neck and neck, sometimes a little worse, sometimes, who knows, a little bit better than seasonal influenza. And of course, the difference is this isn't traditionally a respiratory season pathogen, as it seems to be year-round, often at different levels. For example, this summer was certainly another surge, especially in areas on the West Coast, but also the Northeast and other parts of our country based on wastewater surveillance. And what has also been true is that the vaccine uptake has been reduced for COVID vaccines, with estimates last year that less than a quarter of adults received immunizations and fewer children. Now, what does the vaccine get you if you're immunized? Well, much like seasonal influenza vaccine, perhaps its vaccine efficacy is certainly diminished from the first trials, estimated, less. And who knows if it's 30, 40, 60% does depend, on your immune status and age and so on and so forth. What you sort of see here is that it prevents ED and urgent care visits in about a third. But in terms of severe illness, much again like seasonal influenza, immunizations do help prevent severe illness in both immunocompromised and immunocompetent patients and those over 65 that end up being at higher risk. And you get the benefit where it clearly reduces the chances of long COVID. Now, in terms of just hospitalization risks, which was really an old surrogate that's very hard now to prove with studies, just given the fact that the severity of illness has generally declined now that most people have immunity. The burden of illness has clearly shifted. It's highest at the extremes of age, as you see on the right-hand side, especially in the 50 and older group, but especially 75, 85 and older is where mortality is the highest, and then also in infancy there. Whereas, children for the most part and young healthy adults are at less risk if they're immune competent and don't have significant health problems. Now, for the severe influenza season, just by shifting in comparison, last year, influenza certainly was deemed quite severe, and you can sort of get a sense of the neck and neck aspects and how both COVID and influenza are beginning to mimic a little bit like one another, with the exception that influenza still causes much more disease relatively than COVID in children and young adults. So the COVID recommendations that we had been following last year, just to refresh everyone what they were, in the United States, everyone 6 months and older was recommended to receive it. You could delay it if you had recent COVID, because that's sort of your own immune booster, as it were, against this virus. And you needed 2 doses, or 2 doses were suggested in patients who are immune compromised, and you could spread them apart by 2 months. Or if you were over 65, you would spread them by 6 months. But I would say, and I do some primary care myself, along with infectious diseases, I'd say it was hard to get many of my at-risk patients older patients to get those 2 vaccines. I think many people are just thinking of it as a seasonal respiratory vaccine, getting it with influenza. Now, just looking at the WHO, took a different tact in many countries that may have lesser resources. They sort of viewed things as, who to prioritize, people over 75, people over 50 with comorbidities, any adult with comorbidities, and then special groups such as pregnancy, healthcare workers, and immune compromised. So, clearly the United States had a little more of or had a lot more of a just sort of a blanket recommendation there, because there were benefits to smaller numbers there, but the sense was this is a safe vaccine, so that was the approach given. What's transpired, of course, what I call the new world, at least in the United States, is that there was FDA approvals that are different now. for this updated vaccine, which uses a JN.1 lineage component for this next year season, or the next year. So this is different than the last one, which is probably no longer available in pharmacies, and unless if you have some still left in your freezer. So there are two mRNA products that, at least on FDA approval basis, have universal recommendations for 65 and over, but then are limited to those with health conditions at younger ages. And one difference is that the Novavax, which is, of course, the non-mRNA protein-based vaccine, is only approved in ages 12 to 64, whereas the others are at younger ages, including the Moderna vaccine, which can be given as young as 6 months. Now, what's a lot of people feared from the ACIP, which held its meeting earlier this month, was that there would be some kind of strict requirement or doctor's prescription. And this has proven not to be the case, although I've certainly had pharmacists or patients ask me for a prescription, or else their druggist wouldn't give it to them. But that could have been perhaps now less of a concern. But there's supposed to be shared decision making for everyone in all these conditions. So it's how this will be handled is uncertain there. And we'll talk about it in a moment. But you're supposed to have shared decision making with the emphasis on higher risk people there. And it's still awaiting now a week plus from this meeting for formal adoption, because the CDC director has to sign off on it. And I think it's interesting, we can all agree that this hasn't happened yet, and whether the true recommendations will change and not perhaps be in line with the ACIP recommendation. So uncertain why this hasn't really been signed off, since we're now certainly heading into a season with a vaccine at this point. So here are the key issues as I see them. Yes, 65 and older and people with comorbidities, but you're supposed to do shared decision-making in some form before receiving it, and you don't need a prescription. The thought is probably if you're under 65, you may need to attest to a health condition, but not proof of it there, and that you have to have some degree of discussion. But it can be with a healthcare professional, could be nurses, pharmacists, PAs, advanced practitioners, primary care docs, specialists. But still, if that's a requirement somehow, it's also unclear if there's been a verbal, acknowledgement that you've done this. Do you need to attest to it? There is some confusion there. I think most people believe that all insurers will pay for vaccines, certainly Medicare, Medicaid patients, but the American Hospital Insurance, the insurance group, there has said that they pledged they would cover it. United is not part of that, but have said that they would also agree to cover vaccines. But some of the mechanisms, and I'd be interested if anyone wants to comment on this that's listening today in the Q&A, what they're sort of seeing and facing would be sort of helpful to share. Now, moving to influenza, this is a little easier and a little more certain at this point. But just to look back at last year, it was considered the highest severity year short of the 2009 pandemic, with 13,000 deaths, 280 pediatric deaths, so the highest ever recorded except in that 2009 period. And that most of the children that succumbed, unfortunately, were unimmunized, but half were healthy. So it meant, there's certainly risks, and that's always been true for influenza. with the average age of death being just 7 years. There were many hospitalizations, which is why it was judged of great severity, even though the death toll wasn't perhaps as high as in some other years, with a high percentage needing ICU admission. And that was mainly an influenza A year with H3N2, as well as the old pandemic strain still circulating. And importantly, at least on an antiviral standpoint, oseltamivir and an alternative baloxavir really did not show any significant resistance in the CDC influenza surveillance system. So for influenza, the ACIP was sort of the older panel, and so there aren't really before there were changes, and so there's not much change. There still remains universal immunization at 6 months or more. Much like last year, all are trivalent with just a single B component and two A's, and immunization remains best either in September or October before we head into the November, December holidays and the typical uptick in influenza. So what's new this year? It's not a lot. The recommendations have generally stayed the same, but happy to answer any questions. There is a new self-administration of the live attenuated influenza nasal vaccine there. So you don't have to have it given in the setting of a pharmacy or a medical office. The second, so you can pick it up and then administer it to folks at home that may be bedbound or not easily gotten to pharmacies or pediatricians' offices. The recombinant influenza vaccine has now been approved by the FDA for as young as 9 years, and with a lot of fanfare but little impact, all vaccines were declared to be thimerosal free, which was really mostly the case anyway. And the last is perhaps the underappreciated respiratory syncytial virus. We certainly have a lot still people doing COVID home antigen studies. There are also combination COVID and influenza home testing as well. And of course, you have rapid testing, both molecular and antigen testing for influenza in primary care offices frequently and urgent care. But RSV is generally not investigated until you might end up in an emergency room and requiring admission, which is when it's often part of that panel. So I think we don't really appreciate how much this occurs, at least in the adult population. And certainly for children, this is the season of RSV, which has varied a bit following the pandemic, but seems to be returning to its customary role with the onset of school and a big uptick in RSV, most severe in the under 2 age set. But for adults, there's a growing recognition that people over 65 and certainly over 75 and healthy are at risk for hospitalization, same as with COVID and influenza. But there's also risks in the 50 plus group, especially if there's comorbidities. Estimates are, at least as far as we can tell, that RSV might account for anywhere from 60,000 to 160,000 hospitalizations a year and 6 to 10,000 deaths. So it's less than seasonal influenza, less than COVID, but still substantial. And if you're ill enough to be hospitalized, the thought is the fatality rate is probably about 5 to 10%. Not necessarily always from the virus itself, but because this virus will exacerbate an underlying health condition, such as congestive heart failure, for example. So there's 3 RSV vaccines, with the newest kid on the block being the mRNA vaccine. So this is a bit of a larger landscape here, and there's a couple of distinguishing features, but generally, when these were first FDA approved, they were approved for people 60 and older. And so that's sort of what the initial recommendation was. But I think many like Andy Pavia and others that really study the field of this in adults thought, generally healthy adults in their 60s, even up to 70s without health problems are not really at risk for this being a severe illness. And I think there was recognition and compilation of data such that last year the ACIP changed the recommendation so that it's recommended for all adults over 75 because that's really where risks were the highest, and adults 50 and older in that group up to 75 at increased risk, generally because of cardiopulmonary conditions and so on. And that the recommendation is you can use any of these three vaccines. There's no special one. And it's not annual. That's a very frequently asked question from my patients. Do they need a booster? At the moment, RSV data from Pfizer, I believe, if I remember correctly, shows good 3-year protection data to date. So what are some of the differences here? Are that both Moderna and Pfizer do have an FDA indication as low as age 18. So that's not the ACIP recommendation, but the vaccine can be given as to adults, all adults potentially, if they have a health condition. So what are some of the nuances here that you should know about? Well, on the left-hand side is a pregnancy. And this is for the protection of infants, and it's only the Pfizer vaccine that is approved for this, and it's given in the 3rd trimester to protect infants. And this is an alternative to the monoclonal antibody infused into infants that might be judged high risk as having congenital heart disease, for example. So it offers much wider protection there. Now, for our adults, which was the focus of this webinar, we talked about how if you're 75 and older, that's easy. But then you need a risk factor in the 50 to 74 group, generally cardiopulmonary diseases, for example. And then if you're between 18 and 49, you can use the mRNA or the Pfizer product, but the ACIP does not currently recommend. So this is where you might need a prescription, and insurers may not pay for it, so there may be out-of-pocket expense. And at least for pregnant people, again, the window for administering this is usually September to January, at least here in North America, to offer that protection from the vaccine, which is transmitted by maternal antibodies to the infant. And then just here's the risks for RSV. There's also the standard list of other comorbidities beyond what I've mentioned: liver disease, obesity, immunocompromise, people living in institutions, or there is, at least the FDA gave this proviso that any health condition that a practitioner may be determined to place them at risk of disease. Timing is, if anything, it's great to get it in August or before the fall season, if possible, but it could be given at any time and no boosters required, as I mentioned, with 3 years of data. I'll just finish with 2 quick slides, hearkening to my first slide, that is the issues of increased vaccine hesitancy. There's no doubt making a strong recommendation from you is the most important. I will also mention it's important to have the staff on board. I can't tell you how many times the patients will ask one of our medical assistants, like, what do you think of the vaccine? Should I get it? And I think if you don't inform your staff, there could be some cross purposes there, just to answer questions and make sure they're also on board with what you're thinking. But for people that are hesitant, can you actually move the needle? And it may not be in that visit, it could be others, but it's to try to ask them what they think of the vaccine, what have they heard. Try to use motivational interviewing, which I have a quick slide on coming up. And try to, you don't want to give them the data behind the recommendations like I did here, and why it's important and all of that, because on an individual basis, they're usually worried about safety And, all these vaccines have generally been safe with only very rare complications, which I can happily address if people have concerns during the Q&A. And basically opening the topic, and I know we all have compressed visits now. It's very hard to get into this, but to begin the discussion, I think is important because this is one of the best strategies to prevent illness that's also the least expensive. And for motivational interviewing, this is really rather than a top-down approach. You ask open-ended questions, hear what they have to say. You would try to summarize it back to them and say, I understand. This is what I've heard, for example. Do you acknowledge their concerns? Is there some potential misinformation? Ask, would they like to hear what our thoughts are on some of this, and so on and so forth. Summarize and then go back to them and say, well, what do you think of that? And so on and so forth. So that's been viewed as one of the stronger ways if when you have the time to sort of dedicate to this, which can be accomplished in as little as 2 to 5 minutes. So in summary, as I mentioned, a strong recommendation remains the best chance to immunize our patients. For those that are uncertain or hesitant, especially with mRNA vaccines, the motivational interviewing techniques are very helpful. Please don't confront, and you don't want to say you want to clear up information, but you want to just understand what they understand and see if you can bring any of the information that you are aware of. And actually, I share patient stories. I find that very effective, because I do both inpatients where I see people on ventilators and so on, or if you have family members that have, had problems and so on and so forth, are all very helpful because stories tend to be much more convincing to people in front of you than data. And then lastly, I just wanted to mention, of course, that the Johns Hopkins Antibiotic Guide, we keep up to date with information. I'm still waiting to update our COVID module to see what the CDC director says and our COVID vaccines. So I'm waiting to see what happens on the sign off and so on. But I'll be sure to have older data available so people know what was previously recommended, as well as current ones that might impact insurers and so on for your patients. So thanks so much for listening. I'm going to stop sharing, and I think we have some time for questions.
Yes, thank you so much, Dr. Auwaerter. That was a fantastic presentation. We do have quite a few questions. Hopefully, we will be able to get to as many of those as possible. The QR code that was just shown does offer a 14-day free trial to the Johns Hopkins Pocket Guide. You can also get that information by going to the Unbound Medicine website and filling out a form, and we will be able to get you set up with access there as well.
I'll put it back on at the conclusion. Does that make sense?
Okay. That's perfect. Thank you. And so the first question that we have is, Dr. Auwaerter, have you done any comparisons of the influenza severity between the US and Canada?
No, I haven't. Not that I'm aware of. That I know of. It'd be interesting to know what the basis for that question was, or was it more on vaccine penetration issues or something? So I'm not familiar with that data, to be honest, but thanks for the question.
Perfect, thank you. And then our next question was regarding FluMist, and I apologize if I'm not saying that correctly. The understanding is that self-administration ordering must go through the manufacturer, and pharmacists cannot do that at this time. Is that correct?
I'm sorry, say the question again.
Sure. My understanding for FluMist is that self-administration ordering must go through the manufacturer, but that pharmacies cannot do it at that time, at this time.
Currently, that's true. Yeah, for pickup. Yeah. Mm-hmm. And
then the next one is with the newer RSV vaccines, do they have a lower AFib risk than the original?
A lower, I'm sorry?
AFib risk than the original.
Oh, AFib risk, yes. So the little, so with the mRNA, it looks like that's a little different than the protein adjuvants there. But that's something that's been raised, and I have to say, I haven't seen much about that recently. So I think that's that's something that I tend to just mention to patients. I think if anyone has paroxysmal AFib or they're tenuous, it's important. But I also will say RSV itself will be worse in these patients than the vaccine, right? So, but I think in full acknowledgement, especially in people with cardiovascular conditions, it's a good point to bring up. And in the space of the time limited, obviously there was a lot of topics we didn't cover.
Yes, I think we have time for 2 more questions. So the next one we will get to is, what is the goal for the COVID vaccine since the LP 8.1 lineage is no longer dominant?
Yeah. Well, so this is always an excellent question. Like they made those decisions were made a while ago, right? And it's no longer dominant. So, the protection obviously won't be quite as good, but there's still cross protection. And so, and there could be also T cell responses and other aspects here. And this has been true, obviously, where we're sort of always behind this particular coronavirus. So, yeah, I mean, and we'll see how well it performs, right? It depends a little bit how the lineages diverge. So far, it hasn't been the dramatic ones that we saw earlier years ago, right? So, we'll just see how well it works, but it's the best you have. You have to make a decision, right? Make the vaccine. So, it's always a very valid point. We'll see how it goes.
Thank you. And for our last question, it is almost a combination of quite a few. You mentioned patient stories. Is there a particular story that you found helps reassure persons about the safety of vaccines in general or specific to COVID?
Yeah, no, I mean, I think for me, it's usually I immunize my family, to be honest. Both even my adult children, do get vaccines and, they're in their 20s, for example. I'll just mention my own personal stories there that I do get immunized and why, and that I label concerns. I also, at least to health professionals, tell the story because I understand it. When the varicella vaccine came out, I was afraid when I had my oldest at that time was 5 when it came out, and they're like, "Well, it's a new vaccine. I really don't want to take it." And of course, then he got varicella. It was terrible, and the vaccine, of course, was safe, but we were sort of nervous. So I do understand that, especially with the mRNA vaccines. But I also try to couch that story by saying, if I had known what I know now, and so I say it encourages me to tell people we've had such a vast amount of data with mRNA immunizations, just millions and millions of doses, that we're not really seeing any significant safety signals now, especially since many people have immunity. So, and of course, there's still always rare events. Of course, that's true for any vaccine, but I tend to personalize it as much as possible. And plus, at least for my primary care patients, I know them well enough, so I try to, pitch the story a little bit. So.
Wonderful. Thank you so much. I apologize that we did not have time to get to all of the questions. Please feel free to reach out to, again, webinars@unboundmedicine.com, and we'll see if we are able to answer those in a more one-on-one capacity and hopefully share those in the future as well. Again, this QR code can be scanned for the 14-day free trial to the Johns Hopkins Pocket Guide, where you'll be able to view more information such as that which Dr. Auwaerter presented on today, in addition to other topics. And we look forward to hosting you again in the future for one of our other webinars, which will likely also feature this wonderful speaker, Dr. Paul Auwaerter. So thank you all, and thank you, Dr. Auwaerter.
Great. Thank you very much for listening. Hope everyone has a great rest of the day. Take care.